Hello, everyone, and welcome to our question lab this evening. We're happy to have you here. As you guys know, we do this every Tuesday at 6 p.m. and today's topic is going to be hematology and oncology pharmacology. My name is Sean. I've been with ScholarRx for almost 2 years now, working on the RX Coach Project, which is our new one-on-one tutoring program. And I'll be talking about that here in just a little bit. Joining us today, we have a special guest, and he is actually a radiation oncologist based here in Miami, Florida, and that's Dr. Neeraj Mehta. I'll let him introduce himself.
People even know what radiation oncology is these days.
They're about to.
Anyways, pleasure to meet everybody. It's so exciting to be part of this, and I applaud you guys for grinding it out. This is the best way to do it. My name is Dr. Mehta, radiation oncologist. We use radiation to treat all different types of cancers. We'll go over the mechanism a little bit later. I'm based out of Miami, Florida. I also am a choreographer and I run a movement and music program for people with chronic illness. So trying to combine both, and so happy to be here, Sean. Thanks a lot, and let's get this going.
Sounds great, and it's nice to have physicians that have actually used our resources and are attending physicians. And if they can do it, so can you, and keep that in mind. USMLE-Rx has educated a lot of current practicing physicians. And I think that's a great testament to the great work that the entire team does here at ScholarRx and USMLE-Rx. If you guys look at your control panel on the right side on your GoToWebinar panel, you'll see a question box, and we have some wonderful panelists that are here to help answer your questions. We have Kate and Jeff, who you'll meet later, and one of our panelists, Mark. And Mark, why don't you introduce yourself?
Hello, everyone. My name is Mark Hesslin. I'm a fourth-year medical student at Cooper Medical School in Camden, New Jersey. I've been working with ScholarRx for about 8 months now, helping students with Step 1 and Step 2 CK, and I'm happy to answer all your guys' questions.
Excellent. Thank you, Mark. You've had a chance to meet us. We'd like to get a chance to meet you. So I'm going to ask you guys the question and give you guys a second to respond here. Let us know. Who are you? Are you a MD US Canadian student, DO US Canadian? Are you an IMG from US or Canada, or other, or your dental or podiatric student? Please take a second and let us know. This is the same type of poll format we'll see with all 4 questions this evening, so you'll be able to answer and select what you think is the correct answer with each question. So if this is your first question lab with us, please familiarize yourself with the format of this poll. We'll give you guys a few more seconds here, and then we'll get going. Excellent. Looks like 63% of you guys are international medical students or graduates, and 29% of you guys are US or Canadian born IMGs or students, and we have a good amount of MD and DO students as well. So welcome, everybody. We hope that you find today's session helpful. With that being said, I know a lot of you guys are studying for Step 1, and we'd like to know, when do you plan to take the exam? Please let us know. Do you plan to take it later this year, early next year, sometime later next year, or in 2022 or beyond? We'd love to hear your response. We'll give you guys a few seconds to respond, and then we'll kick it off with our first of 4 questions this evening on hematology and oncology pharmacology. I see the responses are coming in. We'll give you guys a few more seconds here, and then we'll go ahead and get going. All right, and let's go ahead and take a look here. And it looks like a lot of you guys are taking it end of this year. So that's coming up here, and we hope that this session helps you out. And of course, we'll talk about RX Coach later if you want to reach that peak potential on test day. So keep that in mind. Next week, we'll be covering respiratory physiology. So feel free to tune in next week, Tuesday at 6 p.m. when we do respiratory phys. And with that, I'm going to go ahead and kick it off with our first question. We'll talk about RX Coach a little bit later, but the methodology we use today is going to be the same one we use in RX Coach, and we'll talk about that program more as the evening progresses. So with that, I'm going to hand it off to Dr. Mehta.
All right, thanks a lot. So now before we begin, you will see that the answer choices are missing. That is by design. That is because the first thing we do as a part of our methodology is to cover up the answer choices. We do that so the answer choices do not dictate your thought process, and so that you don't see an answer you're unfamiliar with, which may cause you to panic as you're reading the question. The next thing we will do is read deleted. This is the last sentence of the question itself. We do that so that we know what the question is asking, so that we can pick up on the relevant clues as we're reading the question. And hopefully this will also prevent us from having to reread the question and waste valuable time on test day. So let's read the lead-in. A specimen obtained on aspiration of bone marrow is shown. Which of the following is the correct mechanism of action of the anti-inflammatory medication used in this patient's treatment? After we read the lead-in, we ask our students, how many steps does this question require? For example, if this is a one-step question, a two-step question, or a three-step question. We do that so students can keep an organized thought process. And Sean will go over how many steps this question requires in a moment. After that, we will read the question together, one sentence at a time. I normally, during a coaching session, will stop you after every sentence and ask you what is important and what are you thinking and what's on your list of differentials. Since we do not have the time to do that with all of you individually today, I will pause briefly after every sentence so that you can gather your thoughts. Excellent. Let's go ahead and read the question together now. A 4-year-old boy is brought to his pediatrician by his mother because of fever, fatigue, and dizziness during the past several weeks. His mother denies that he has had any nausea, vomiting, or diarrhea. She notes he has no major past medical history and that he has received all of his scheduled immunizations. On physical examination, the boy appears pale with petechiae across his legs. There is palpable lymphadenopathy. A complete blood count shows WBC count 51, hemoglobin 9.1, hematocrit 26%, platelet count 122, neutrophils 22%, lymphocytes 73%, monocytes 3%, eosinophils 1%, basophils 1%. A specimen obtained on aspiration of bone marrow is shown. Which of the following is the correct mechanism of action of the anti-inflammatory medication used in this patient's treatment?
Wonderful. Thank you, Raj. Normally at this point in our question lab, we ask you guys how many steps does this question require? But today we're doing things a little bit differently. So what I want you guys to do is take a second to look at this question and let us know in the question box what you think the most important keywords in this question stem are. So we'll give you guys a few seconds to respond in the question box and let us know what do you think are the keywords and clues in this question that are going to help us get to the right answer. So we'll give you guys a few seconds to respond and let us know what you think those clues are. I see somebody saying 4-year-old. What other clues do you guys see in the question stem that are important? Feel free to type out more than one thing as you're doing it. Age and clinical features, fever, fatigue, anemia, high lymph count, excellent. So we're getting a lot of good responses here and a lot of different responses here. And that is why we're doing this. We want to make sure that we're dissecting this question the right way and picking up on the relevant clues so that we can answer the question and get to the right answer. So I'm going to go ahead and show you what I've highlighted to be the important clues, and let's talk about that. A 4-year-old boy. We know he has fever, fatigue, and dizziness. His mother denies that he has any nausea, vomiting, or diarrhea. He appears pale with petechiae, has lymphadenopathy. We see some important lab values highlighted here, hemoglobin, hematocrit, lymphocytes. And then in the lead-in in yellow, you see mechanism of action of anti-inflammatory medication. So I want you to keep those clues in mind as I read to you these answer choices. Answer choice E, formation of an intracellular receptor complex. Answer choice D, formation of a plasma membrane prednisone glucocorticoid receptor complex. C, binds to DNA as an alkylating agent. B, binds as an antagonist of the glucocorticoid receptor. And A, binds as a mixed agonist-antagonist of the estrogen receptor. I'm going to go ahead and open up the poll here and give you guys a few seconds to select what you believe is the correct answer. So we'll give you guys a few seconds here to respond, and then we'll go over the incorrect and correct responses together. All right, we'll give you guys a few more seconds to respond here. I see the answers are coming in a little slowly, but that's okay. Take your time. Think about those clues that are highlighted for you. And then let us know what you think the correct answer is. Looks like about half of you guys have voted. We'll give you guys a few more seconds. Remember that on test day, there is no penalty for guessing, and certainly not one tonight. So if you're unsure what the answer is, do me a favor, take your best guess, and we'll go over everything here in just a moment. All right, let's see what you guys selected. It was close. 30% of you guys picked answer choice E, formation of an intracellular receptor complex. And in second place, almost tied with third place, was formation of a plasma membrane prednisone glucocorticoid complex. So let's see what the correct answer is. And the correct answer is E, formation of an intracellular receptor complex. So 30% of you guys got that question right. Great job to those of you who got it right. For those of you who didn't, don't worry. Let's talk about why this is right and why the other ones are wrong. So formation of an intracellular receptor complex, that's the correct answer. And this is probably a two-step question. First, we need to figure out which drug they're talking about and then figure out what the mechanism of action is. So this patient presents with recent onset fevers, fatigue, and dizziness. And we've highlighted that for you as relevant and important clues. And these clues are important, but they lead to a generally pretty broad differential diagnosis, right? But now we also have a CBC, and the CBC shows leukocytosis, specifically lymphocytosis, with mild anemia and thrombocytopenia. So when you see this combination, it's going to raise the suspicion for bone marrow disease, which is best investigated with a bone marrow biopsy. The patient's biopsy specimen, which we showed you here in the question, demonstrates hypercellularity dominated by lymphoblasts, which is diagnostic for ALL, or acute lymphocytic leukemia. Now let's talk about treatment for ALL. Treatment for ALL is divided into three phases: induction, consolidation, and maintenance. Induction is designed to put the patient in remission and usually consists of treatment with vincristine, L-asparaginase, and prednisone. Prednisone acts as an agonist, passing through the plasma membrane and binding to the intracellular glucocorticoid receptor. This prednisone glucocorticoid receptor complex then travels to the nucleus, where it binds to inverted DNA repeats, causing activation or suppression of specific genes and leading to apoptosis of immature lymphocytes. The prednisone glucocorticoid receptor complex also leads to the production of anti-inflammatory proteins and suppresses cytokine synthesis. Prednisone also suppresses neutrophil migration and inhibits the production of COX-2. So that's why E is the right answer. Let's talk about why the other answer choices are incorrect. Let's start with answer choice D. And if you notice, we always start with answer choice E and work our way up. And the reason we do that is because we want to make sure that you get through all of the answer choices before prematurely selecting one that you may think is the right answer. So answer choice D, formation of a plasma membrane prednisone glucocorticoid complex. Remember that membranes are made of fat, which means that all lipid soluble steroids can freely cross that membrane because they too are made of fat or lipids. And as a result, the glucocorticoid receptor is intracellular. So steroids of any sort will pass through the lipid or plasma membrane to bind to the glucocorticoid receptor, forming an intracellular complex, okay? So that's why D is wrong. C, binds to DNA as an alkylating agent. Well, alkylating agents such as cyclophosphamide, they will covalently bind and alkylate DNA. And cyclophosphamide is used to treat non-Hodgkin lymphoma, leukemia, breast cancer, and lung cancer. This is not the mechanism of the anti-inflammatory drug that the patient would be prescribed. And we highlighted here anti-inflammatory medication because sometimes we read things and we kind of forget when we get anxious or we're taking a test and we forget what the test writer is asking. But they very specifically told us they're looking for an anti-inflammatory medication, and cyclophosphamide does not fit that description. And let's talk about B. Now this binds as an antagonist of the glucocorticoid receptor. We're talking here about mifepristone, also known as RU486, and that works as both an anti-glucocorticoid drug and an antagonist of the progesterone receptor. So in the latter capacity, it is used in the medical termination of pregnancy or abortions. And glucocorticoid antagonists have no role in the treatment of this patient's disease. And if you also look at the clues we highlighted, we said that this patient denies any nausea, vomiting, or diarrhea. And that's a good exclusionary clue, because if we did not know that, we would not know that some of these drugs are automatically ruled out, because a lot of these medications will cause nausea, vomiting, and diarrhea. And RU486, along with chemotherapeutic agents, are definitely going to cause that those GI symptoms. But the test writer told us, and we highlighted, that this patient did not have those symptoms. So that should help us rule it out. But then again, our biggest clue here was they told us it's an anti-inflammatory medication. Answer choice A. Binds as a mixed agonist or antagonist of the estrogen receptor. Now these are SERMs, these are selective estrogen receptor modulators such as tamoxifen or raloxifene. And they do act as mixed agonists and antagonists of the estrogen receptor. Tamoxifen is used to treat estrogen-dependent breast cancers, whereas raloxifene is used to prevent osteoporosis. So this patient would not be prescribed a SERM or a selective estrogen receptor modulator. And once again, it's not A for ALL, but also B, it is also not going to be used as an anti-inflammatory medication. So great job to everybody who got that question right. If you didn't, hopefully that explanation helped you out, and we'll do better going forward. And with that, I will turn it back over to Dr. Mehta.
I mean, I just wanted to say, we can't forget about those steroids. Good old-fashioned anti-inflammatory drugs that we use pretty much in so many different cancer diagnoses. So that's a phenomenal question. I think that would definitely be indispensable. All right, question 2. We will read the lead-in together first. Here we go. In addition to stopping the heparin, which of the following is the best next step in treatment? All right, here's a question. A 69-year-old male is evaluated in the hospital for bilateral swelling and pain in his legs. He was admitted 5 days earlier for management of a pulmonary embolus with intravenous heparin. Ultrasonography reveals the presence of bilateral occlusive thrombi in the patient's popliteal veins. Laboratory tests show a platelet count of 27,000, prothrombin time of 12 seconds, and an activated partial thromboplastin time of 65 seconds. In addition to stopping the heparin, which of the following is the best next step in treatment?
Excellent. Thank you, Raj. So now, once again, I want to ask you guys, what do you think are the important clues in this question? So pick out 2 or 3 of the most important clues and type it into the question box, and let's see how you guys do, and we'll discuss it together in just a second. I have somebody saying low platelet. Great. What else? What other clues do we see? If you had to pick 2 or 3 clues, what 2 or 3 clues would you pick and designate as the most important? We have platelet count and increased PTT. Excellent. We see some good responses coming in. Once again, different responses. So we will go over these clues in a second. Wonderful, guys. I see a lot of great responses coming in. Keep it up. So here we go. I've highlighted some things for you. one of the most important things here is we already know that we're stopping heparin, right? So that was told to us in the lead-in. So that really sets the stage for us as we're reading this question. So now we have to figure out what happened as a result of this heparin, right? So when you see that, there's really only two choices, right? You're going to have an overdose of heparin, or you're going to have HIT, or heparin-induced thrombocytopenia. So let's take a look at these clues and see what they're leading us towards. So we have bilateral swelling in the pain and legs. What do you think causes that? And we have he was admitted 5 days earlier for a PE and that's when he was given the heparin. And ultrasound shows bilateral occlusive thrombi. Look at his platelet count, prothrombin time of 12 seconds, and APT of 65 seconds. So I've highlighted some clues for you. I've given you some additional clues, and now we're going to uncover these answer choices and see if we can't get to the right answer. Once again, we'll start with answer choice E, and we do that by design. The reason we do that is because we do not want you to start at the top, go down, pick an answer prematurely without reading all of the answer choices. So this is going to help us make sure that you go through all of them. Answer choice E, warfarin. D, vitamin K. C, protamine sulfate. B, direct thrombin inhibitor. And A, aspirin. I'm going to give you guys a second here to let us know what you believe the correct answer is, and then as always, we will go over the correct and incorrect answer choices. So we'll give you guys a few seconds here to respond. Excellent. I see the answers are coming in. They're coming in strong, so keep it up. This is definitely a high yield topic. Between heparin and warfarin and HIT and overdose, this is something that's not only highly testable, but it's something you're going to see in practice. So it's important that you realize that your end goal is not just to pass the exam. Your goal is to become a physician here like Dr. Mehta, right? And if he can do it using our resources, so can you. All right, let's see what the correct answer is. Well, first, let's see how you guys did. So you guys selected 43% of you guys selected C, protamine sulfate, and 31% of you guys picked B, direct thrombin inhibitor. So there were really two ways we could have gone in this. We could have gone with overdose or HIT, and a lot of you guys went with overdose, when the correct answer is direct thrombin inhibitor, and I'll tell you why in a second. But first, this is probably a one-step or a two-step question, right? So we have to figure out what's going on and then what we can do to stop it. So if you look at the clues here, the lab test and the ultrasound findings suggest that this patient has developed HIT, or heparin-induced thrombocytopenia. Now, this is a rare but clinically important complication that typically manifests 5 to 14 days after heparin use. What happens is these IgG antibodies develop against heparin-bound platelet factor 4, and the resulting complex leads to platelet activation, clot formation, and steadily dropping platelet levels. Now, the proper treatment for HIT is to immediately stop heparin, okay? And they told us, in addition to stopping the heparin, what do we need to do? And that right there is a great clue, because they're telling us that we have to stop heparin. So we know now that the problem is related to heparin. And like I said, we can only go one of two ways there, and that's going to be either overdose or HIT, right? And the proper treatment for HIT is to immediately stop heparin therapy and then to treat the patient with direct thrombin inhibitors such as argatroban and lepirudin. Now, as the name of this drug class implies, these drugs directly inhibit the activity of free and clot-associated thrombin. And that is why B, direct thrombin inhibitor, is the correct answer. Now let's review why the other answer choices are incorrect, starting with warfarin, okay? Warfarin is an effective treatment for preventing thrombus formation, but it usually takes at least 5 days to take effect. Furthermore, warfarin would actually be contraindicated in this patient because it should not be administered to patients with HIT until the platelet count is greater than 150,000. So that platelet count that they gave us is another reason why this answer choice is not going to be the correct answer, okay? Now, warfarin can also cause an imbalance between the anticoagulant and procoagulant proteins during its first few days of dosing, and excess anticoagulation can lead to skin necrosis and venous limb gangrene. So this is definitely going to be a contraindicated drug in this patient. Now let's move on to answer choice D, vitamin K. Now, vitamin K is used to reverse the effects of warfarin and other vitamin K antagonists. Now, we can deliver this intravenously in emergent situations, but it would not be helpful in this patient because we already know that this patient was given heparin. Now, protamine sulfate. Now, protamine sulfate is used to counter heparin overdoses because it readily binds heparin. However, there is no evidence to suggest that this patient received an overdose of heparin. And this can be tricky for students, and they oftentimes confuse an overdose with HIT, but look at the symptoms of HIT, and they're highlighted here for you, and you'll be able to get this right. And I'll actually even show you a slide here in a little bit about heparin so we can talk about that in a little bit more detail. B, we discussed, we said that was the correct answer, so let's move on to answer choice A. Now, aspirin is an effective therapy for preventing thrombus formation, but it would do little to counteract this patient's hypercoagulable state, and we know he's in a hypercoagulable state because of the PE he had in the past, and of course now the bilateral occlusive thrombi that the test writer and the question writer told us this patient is experiencing. So I hope that explanation helped everybody out and that we've learned about heparin. But just to drive that point home, here's a nice little slide from first aid on heparin. As you can see here, it is used for immediate anticoagulation. And the way I remember that is heparin comes first in the alphabet, warfarin comes later, acute comes first in the alphabet, chronic comes later. So heparin is used for acute conditions and warfarin is used for more chronic conditions. Now, HIT here is one of the adverse effects, okay? And we can eliminate that by trying to give some low molecular weight heparins, as it says here, right? But HIT is really going to be categorized by that hypercoagulable state, by a drop in platelets. But just keep in mind that heparin, whenever you use it, HIT is going to be a risk factor, and you're going to want to monitor for it, and test writers are definitely going to ask you about it, and you will certainly see it in practice. So with that, I'll tell you guys a little bit about RX Coach. If you like the way we're dissecting questions and pointing out clues to you, we're working on developing your test taking skills. And that's just as important as reviewing the material. And a lot of people come to me and say, hey, I took a USMLE prep course. Well, unfortunately, most USMLE prep courses, if not all of them, do not really address test taking skills. They address content and knowledge only. So what we like to do is we start with a 160 question assessment. Based on an assessment, we'll analyze your strengths and your weaknesses, and we'll come up with a personalized study plan. And then we'll use a one-on-one approach to strengthen your knowledge, to bridge those knowledge gaps and identify your test-taking skills and strengthen them so you can achieve maximum potential and your maximum score on test day. We have highly trained RX certified tutors. They undergo hours and hours and hours of training before they see their first student. And of course, we give you access to RX 360 Plus, which includes RX Bricks, RX Express videos, our flashbacks, and of course, our QMax question bank, which is what we're using in tonight's session. You can see here a wonderful testimonial with a student whose score went up 35 points. We had a testimonial last week we shared with a student whose score went up 73 points. We had a score come in yesterday from a student who got a 247 on step 1. So these are just some recent success stories, and if you'd like to be one of them, please visit us at www.rx-coach.com and sign up for a free consultation to discuss our program and how it can benefit you. All right, with that being said, we're halfway done with the evening. We got 2 questions down, we've got 2 to go. So let's see if we can finish strong, and I'm going to hand it off back to Dr. Mehta.
All right, here we go. Question 3. We'll do the lead-in as usual. Which of the following is the major mechanism of the chemotherapeutic agent that was most likely used to treat this patient's seminoma? Now, with the question. A 24-year-old man comes to the physician for a routine physical examination before beginning a new job. The physician notes a small firm nodule on the patient's left testicle, and he is subsequently diagnosed with testicular seminoma and referred to an oncologist. Soon after beginning high-dose chemotherapy, the patient returns to his primary care physician because of a 1-week history of dry cough and shortness of breath. His temperature is 98.7 degrees Fahrenheit, 37 degrees Celsius, and his pulse is 82. His respiratory rate is 17. A cardiac examination discloses no murmurs or gallops, and both lungs are cleared to auscultation without wheezing. There is no dullness to percussion. Imaging results are shown. Which of the following is the major mechanism of the chemotherapeutic agent that was most likely used to treat this patient's seminoma?
Excellent. Thank you, Raj. So once again, we're going to ask you to let us know, what do you think are the most important clues in this question? So take a second, let us know what you think the 2 or 3 most important clues are in this question. Then we'll review them together and make sure we're on the right track before we uncover the answer choices. And then we'll go over the correct and incorrect answers. So we'll give you guys a second here to respond. And I see some people already trying to mention the drug, but remember, this isn't asking us what the drug is. It's asking us what the mechanism of action of the drug is. So it's a 2-step question. So keep that in mind and let us know, what do you think are the important clues in this question? We have somebody saying cough after chemo. We have somebody saying 1-week history of shortness of breath, cough, shortness of breath. What about that image? What do you guys see in that image? And what clues are in the lead-in itself? And I see somebody said testicular seminoma. Excellent. Well done. So let's see here. So I've highlighted some clues for you. Testicular seminoma, high-dose chemotherapy, 1-week history of dry cough and shortness of breath. Both lungs are cleared to auscultation. We have an image there, and we're looking for the major mechanism of chemotherapeutic agent to treat this patient's seminoma. So with those clues in mind, and the fact that you know now it is a 2-step question, and an emphasis on the fact that they're not asking for the drug, they're asking for the mechanism of the drug, please take a second to read these answer choices with me, and then I'll open up the poll. Answer choice E, stabilization of microtubules against depolymerization. D, inhibition of topoisomerase 2. C, inhibition of microtubule polymerization. B, formation of superoxide or hydroxide radicals. And A, alkylation of DNA. So I'm going to open up the poll and give you guys a few seconds here to respond, and then we'll go over the correct and incorrect answer choices before moving on to our last question of the evening. Great job on picking up these clues. And as you can see, we highlight them, and what that does is it really shows up nice and clearly, so we don't have to reread the question, and we have nice, organized, and visual to aid us in our thought process as we try to get to the right answer. Oftentimes when we're taking tests, we get flustered, we get anxious, we get nervous. But if you keep your thoughts organized, you keep your clues in line, you will fare better on your exam than you would have if you didn't do that. All right, we'll give you guys a few more seconds here to respond. Looks like we have a lot of people leaning towards one answer, which is normally a great sign, right? You guys seem to be on the right track. Give you guys a couple more seconds here, and let's see how you guys did. Looks like 39% of you guys picked formation of superoxide or hydroxide radicals, and it was a tie for second place, really, with alkylation of DNA and inhibition of microtubule polymerization. So let's see what the correct answer is, and the correct answer is B. So great job to 39% of you guys got it right. For those of you who didn't, don't worry, we're going to go over the answer choices now and the correct and incorrect answer choices as well. We will, of course, start with the correct answer, which is B. So this patient presents with a history of dry cough and shortness of breath. So you have an axial CT of the lower chest, and that shows you cystic degeneration of the posterior lung bases with interstitial thickening or fibrosis and cyst formation. So what we're leaning towards here is pulmonary toxicity, and a lot of you guys picked up on that. And pulmonary toxicity and fibrosis are often associated with a drug, which many of you also mentioned, which is bleomycin. And that is a chemotherapeutic agent used as a first-line treatment for testicular tumors. And if this question looks familiar to you guys, it should be, because we've done it together in a question lab in the past. So bleomycin, what is it? Well, bleomycin is a mixture of glycopeptides that have the unique feature of producing superoxide and hydroxyl radicals that will attack DNA bonds and cause fragmentation. Bleomycin can also cause skin changes and alopecia. So the answer here is B, because of talking about bleomycin. Now let's talk about why the other answer choices are incorrect, starting with answer choice E. Stabilization of microtubules against depolymerization. Does anybody know what drug they're talking about here? Let us know in the question box. What drug is this? It's one of those drugs that students always get right? It is, of course, paclitaxel. And paclitaxel, people usually get right, but what they normally forget is where it works, and it works in the M1 phase. It's an M1 phase specific chemotherapeutic agent that either enhances the polymerization of tubulin, which then prevents the depolymerization of microtubules and causes mitotic arrest during anaphase. So it causes arrest during anaphase. And that is normally a detail that students tend to let slip. So we've gone over it today, so hopefully it'll stay in your memory. Now, paclitaxel is usually used to treat ovarian and breast cancers, not testicular cancers. So we know that this can't be the answer choice because we're treating a testicular cancer. Now, some of the major side effects associated with paclitaxel will include hypersensitivity and neutropenia, not really pulmonary toxicity, which is what we're talking about again. So this answer choice is not going to fly for two reasons. One, we're talking about testicular cancer, and two, this drug will not cause pulmonary toxicities. And those were some of the important clues we highlighted in the question step. Excellent. Let's move on now to answer choice D. Now, this is talking about a drug that inhibits topoisomerase 2, and that drug is etoposide. It's got topo right in it, just like topoisomerase, right? So etoposide acts by inhibiting topoisomerase 2, and the most common adverse effects associated with etoposide include myelosuppression, GI upset, and alopecia. You don't really see pulmonary side effects or symptoms with this drug. So once again, the pulmonary side effect clues as well as that CT are really going to help us rule out etoposide. And then we have inhibition of microtubule polymerization, and this is vincristine. And vincristine binds to the tubulin dimer to prevent microtubules from polymerizing, and it's used to treat ALL, Wilms tumor, and lymphomas, but it is not used for testicular carcinoma. So that's our first clue that's going to be an exclusionary clue to rule out vincristine. And some of the side effects of vincristine are going to include cellulitis and peripheral neuropathies. Now, vinblastine is also a similar drug, and we can use that to treat testicular cancer. But the adverse effects are also going to be like vincristine, more of a peripheral neuropathy picture as opposed to these pulmonary side effects, which we are seeing now, okay? So vincristine is not used to treat testicular cancer. Vinblastine can be, but the side effect profile that we highlighted here does not line up with vinblastine, which is why that answer choice is incorrect. We covered answer choice B. That was the correct answer, so let's move on to answer choice A. Mitomycin C. This is talking about mitomycin C, which is a broadly active anti-neoplastic drug that alkylates DNA. Now, this drug is a little bit tricky because it can cause bronchospasm after administration, but it will not produce the types of fibrosis that we see or the cyst formation that we see here in this patient, okay? Another drug that alkylates DNA is busulfan. And that's an alkylating agent that is associated with pulmonary complications. Now, even though busulfan can cause pulmonary complications, it is not used to treat testicular cancer, which is why we're going to rule out the drug busulfan, right? So mitomycin's out, busulfan's out. Now we've got doxorubicin. Doxorubicin is also a DNA alkylating agent, and it also generates free radicals, but its main adverse effect is ventricular dilated cardiomyopathy, okay? So this is going to eventually precipitate heart failure, and we use doxorubicin for solid tumors, leukemias, and lymphomas. So once again, not used to treat testicular cancer, and the side effect profile doesn't match, okay? So for all those reasons, the other answer choices are incorrect, and B is the correct answer. And we are, of course, talking about bleomycin. And here's a little slide on bleomycin. As we can see here, it induces free radical formation. It causes breaks in DNA. We use it for testicular cancer and Hodgkin lymphoma. And here we go, pulmonary fibrosis, right? As I mentioned, it can cause skin pigmentation and minimal myelosuppression. So keep that drug in mind. It is a high yield drug, and you're likely to see it at least on an exam in med school, if not on your boards. So we're 3/4 of the way done. We've got one question left this evening. Let's try to finish strong. I'll hand it back off to Dr. Mehta.
Yeah. Interestingly enough, I just wanted to add that the mechanism of radiation is quite similar to the mechanism of bleomycin. It actually produces free radical formation, which in turn causes DNA strand breaks. And I couldn't help but notice, someone noted that the mechanism of action of bleomycin is not fully understood. They're right in the sense that how these free radicals cause the DNA strand breaks, but free radicals are still the key. So I just thought that was interesting. Question 4. Here we go with the lead-in. Which of the following elements of this patient's history make her a good candidate for tamoxifen prophylaxis? So a 52-year-old woman with a history of hyperlipidemia and deep venous thrombosis treated with heparin visits her primary care physician after seeing an advertisement for breast cancer prophylaxis with tamoxifen. She was diagnosed with acute lymphoblastic leukemia during childhood and has been in remission for 40 years. At age 47, the patient had a hysterectomy to treat uterine fibroids. The patient has 1 to 2 drinks per week. She does not use tobacco or illicit drugs. She is interested in breast cancer prophylaxis because one of her first-degree relatives was recently diagnosed with HER2-positive breast cancer. After weighing the potential risks and benefits, the physician recommends tamoxifen prophylaxis for this patient. Which of the following elements of this patient's history makes her a good candidate for tamoxifen prophylaxis?
Excellent. Thank you, Raj. So once again, we're going to look at the clues here. And if you look at this question, it's really a unique question, right? Because they're asking us what in this patient's history is going to make her a good candidate for tamoxifen prophylaxis, which means the answer to the question is actually in the question, right? So take a second and let me know, what do you think the important clues are here in this question? I see somebody here saying estrogen receptor. I see somebody saying hysterectomy is done, so they don't have a uterus. Familial history. So some great responses here. Let's see. And of course, you are all correct. 52-year-old woman, hyperlipidemia, DVTs, treated with heparin. She's on tamoxifen, diagnosed with ALL, hysterectomy to treat fibroids, relatives recently diagnosed with HER2-positive breast cancer. And what makes her a good candidate for tamoxifen prophylaxis? So I will tell you that the answer to this question is in green. So which one is it? I'll give you guys a second to read this with me, and then we'll respond and see what the answer is. Answer choice E, uterine fibroids treated with hysterectomy. D, hyperlipidemia. C, family history of HER2-positive breast cancer. B, DVT 5 years ago treated with heparin. And A, childhood leukemia in remission for 40 years. So we'll give you guys a second here to respond and let us know what you think the correct answer is. And then we'll go over how you guys did in the incorrect and correct answer choices. And then, of course, we have a raffle at the end every single time, and you must be present to win. So make sure you stick around. We'd hate for you to win and not be here to collect your prize. We'll give you guys a few more seconds here, and then we will go over the correct and incorrect answers. Great job, everybody. We're happy that you were able to join us. And remember, next week we'll be covering respiratory physiology. All right. Well, it looks like we finished strong because 60% of you guys got the right answer. E, uterine fibroids treated with hysterectomy. So very well done, everybody. A lot of you guys picked family history of HER2-positive breast cancer. But remember, that was important, and we'll talk about why in just a second. And then we have DVT treated 5 years ago, DVT 5 years ago treated with heparin in kind of a third place situation here. So I already told you the correct answer is E, uterine fibroids with hysterectomy, and let's talk about why that is the case. Now, you can see here, I went ahead and highlighted those clues for you, but let's talk about why E is the important one. So tamoxifen is a SERM, and we talked about SERMs earlier. SERM stands for selective estrogen receptor modulator. So what it does is it acts as an estrogen antagonist for binding to receptors on DNA and breast tissue, and as an estrogen agonist in endometrial, bone, and hepatic tissues. So tamoxifen will inhibit estrogen-dependent synthesis of transforming growth factor beta. Its anti-estrogenic effects on the breast explain its efficacy as a treatment for estrogen receptor positive breast carcinoma and as a prophylaxis for women who are at high risk for this disease. Yet, women who take tamoxifen are at an increased risk for endometrial carcinoma because of its stimulatory effects on the endometrial estrogen receptors. Now, other adverse effects of tamoxifen do include hot flashes and thrombosis. And SERMs have been shown to reduce the risk in breast cancer in women greater than 50 years old. And the benefits of tamoxifen prophylaxis exceed the risks only in those who have had a hysterectomy. Now, tamoxifen is well known to cause a state of hypercoagulability and hypertriglyceridemia. Now, patients with these pre-existing conditions are at a risk of exacerbation if they're started on tamoxifen. So if this question asked us what things may deter us from using tamoxifen, we might say answer choice B, but that is not what the question asked. The question asked her what made her a good candidate, not what made her a bad candidate, okay? So that's why E is the correct answer. Now, let's talk about answer choice D, hyperlipidemia. Now, a medical history of hyperlipidemia would not make this patient a better candidate for tamoxifen prophylaxis, as we just mentioned. In fact, tamoxifen should be used with caution in patients with hyperlipidemia, as a few cases of hyperlipidemia in women treated with this drug have been reported. It's believed that tamoxifen increases plasma triglyceride levels by stimulating production of VLDLs in the liver, also known as very low density lipids, or VLDLs. So once again, you know, tamoxifen's benefits outweigh the risks only in patients who have had a hysterectomy. This question didn't ask us what would rule this out. It asked us what would help make this patient a good candidate, not a bad one. Answer choice C. Here we're talking about tamoxifen, which we talked about a little bit earlier, right? So we know that tamoxifen is used to treat ER and PR positive breast cancer. And here we also have a drug introduced, which is trastuzumab, right? Trastuzumab is a monoclonal antibody against the HER2 receptor. It is the adjuvant treatment in metastatic HER2 positive breast cancer, but this drug is very expensive, and it's also associated with cardiotoxicity. And so prophylaxis with this drug is going to be very controversial and not recommended. B, DVT 5 years ago treated with heparin. Well, tamoxifen is contraindicated for patients with a history of DVT because the drug is known to increase the risk of thromboembolic events. So just like oral contraceptives, tamoxifen can increase levels of procoagulant factors, including fibrinogen, prothrombin, factor 7, 8, and 9. And these drugs can also decrease inhibitors of hemostasis, such as antithrombin and tissue factor pathway inhibitor, okay? So that is not why this patient is a good candidate for this drug. If anything, it's the opposite, right? A, childhood leukemia in remission for 40 years. Tamoxifen is not known to affect the risk of cancer related to the blood or hematologic malignancies. So that is not going to be the reason why. But Most of you guys already knew that because 62% of you guys got that right. So very well done to all of you. I know earlier today in our question lab, we talked about ALL. And here is a brick on ALL. And if you guys haven't looked at RX bricks, take a look. If you haven't looked at the RX resources, take a look. We have a doctor joining us today who used first aid and resources, and he's now a radiation oncologist here in Miami, Florida. And we have hundreds, if not thousands and thousands and thousands of current practicing physicians that have used our resources, and they've gotten to where you eventually want to be. So ALL, the brick here starts off with the learning objectives, and you see them nicely and clearly laid out. You have a case connection here, so you can have that clinical correlation and that case connection to help really make those connections and learn this material and know how to apply it. So you have a learning module here with some nice content that's very clearly laid out, flashcards to help you retain and practice that information. Here's a clinical presentation. And as we keep going and learning more about ALL, right, we not only strengthen our knowledge, but we get to a point where we can eventually test our knowledge and make sure that we learned what we were supposed to learn. So we have a summary here with our key take-home points of what you should learn from this brick. Then we have practice questions that we can use to practice our knowledge, and once you get the right answer, you will see the explanation of why that answer is in fact the correct one. And then you can scroll down here and see this in training session, right? And here you will see an opportunity to review a learning objective, so you can mark them off based on how confident you are with them. And of course, if you want to go deeper, you can go directly into first aid, you can go into flash facts, you can go into express videos, and you can go directly into our question bank. And I think this is very helpful because oftentimes we have so many resources, we're flipping back and forth, but we all have first aid, right? So this really helps us keep everything organized and helps us learn in a way that allows our thought process to also stay organized as a result. All right. So one thing that we did want to do today for you guys was give you guys, for those of you guys who have COMLEX, here are the question ID. So feel free to take a screenshot of this, write it down, take a picture with your cell phone. And if you type these question IDs into COMLEX in the search field, you will be able to pull up the questions that we did today so that you can review them and really hone in on those points that we made today. So I'll give you guys another second here. Either take a picture or write these down.